Wait, is the audio good on there? Well, probably. Hopefully.
Oh, you're just gonna do audio, right? And
Yeah,
then
just
picture.
yeah, and then annotate over it because I like that style. Is it recording now?
Yes.
Okay, well, we've been recording this entire time. We're going to do about 80% of pathophys for FOM6. Sucks to be here. I'm going to start at the top left corner where we have all our leukemias, then go on to the lymphomas. Then I'll talk about the immunodeficiencies after that. And then we'll go on to the anemias and then the clotting disorders at the very end on the right. So starting at the top, we have, if you go to our hematopoiesis, we have our lymphoid and myeloid lines. And so those will have different diseases. We'll start with the lymphoid ones. One of the most common ones we'll talk about, actually, I'll skip hairy cell first. I want to talk about ALL. BALL or BALL. I like to say just BALL tall for B cell or T cell ALL, which stands for acute lymphoblastic leukemia. Lymphoblastic because you're dealing with the lymphoid precursors. The leukemia in ALL, the disease is caused when the leukemia cells replace your bone marrow. And you usually see it after 5 years old, and it is associated, I believe, with trisomy in one of these. We will get to that whenever I get to it. So starting with BALL, you have two different mutations that are associated with it. You have the T12, the translocation of 12 and 21, which has a better prognosis and you generally see in children. And then you have a translocation of 9 to 22, our famous Philadelphia chromosome. There's one more disease we will talk about the Philadelphia chromosome, but we'll get there when we get there. That usually has a poor prognosis, and you will usually see that in adults. For presentation, one of the important things to know for presentation for BALL is that you'll have bone pain. That's pretty big. And then you also have lymphadenopathy, hepatosplenomegaly, and your B symptoms. Your B symptoms being your fever, your weight loss, and your, what's the last one? What is the last B symptom? Why am I forgetting it? Anyone? Please?
It's malaise.
Is it malaise? There's supposed to be three. We should know these. Uh-oh.
Night sweats.
Night sweat. Oh, I think it is night sweats. Yeah, you're right. So night sweats, weight loss, and wait, did I already say night sweats? I already forgot the third one.
Fever, night sweats, weight loss.
Fever, night sweats, weight loss. Okay. Ooh, lecture's already going great. You have three different types on histology that you'll see. So if we look at the cell really quick, you'll just see B cell, and it'll have two little inclusions that are kind of show up a little more like translucent, I guess, or white appearing on histology. For L1, the type to L1 BALL, you'll have the cells will be more uniform. In L2, they will vary a little more, and then L3, you'll actually see some granulations inside of the cell. So those are different ways to classify your different BALLs on histology. As for lab findings, you will find your TDT plus, and your TDT plus are usually seen on your lymphoid precursors. So you'll also see that on the TALL. You'll also have CD19 and 20, which are associated a lot with B cells, and you'll be CD10 positive. And the CD10 positive, I believe, is an important distinction between this and TALL and one other disease when we get there. Or maybe it's just TALL. But speaking of TALL, that will be T cell mediated ALL. You usually see it in adolescent males, and they'll present often with a thymic and mediastinal mass. And then for lab findings, again, you have TDT plus because you have a lymphoid precursor. Then you'll have CD1A plus, and then you'll also be positive for CD2 through 5, if 2 through 8, which includes CD5, which is T cell associated. And this is important later when we talk about other B cells, because again, if they express CD5, you already know that's abnormal because it's only supposed to be on T cells. And then the important distinction is it will be CD10 negative as well. I don't really have a histology slide on there because I guess they didn't really care about that or emphasize that as much as the BALL. Moving on to hairy cell. Oh, hairy cell, just because it's in the corner there. It's an indolent disease and it presents mostly in middle-aged men. It presents with pancytopenia, splenomegaly, and bone marrow infiltration. It's not the most specific disease when you have the presentation like this. But what will really get you there is the histology, where you'll have your, well, it's named hairy cell, where your lymphocytes will have basically hairy cytoplasm. It'll look, spiky, pokey, fuzzy. And then for lab values, you'll have your CD19 and 20, because again, lymphocytes. And then you'll have IgG, but the big important thing to note here is that it'll be trap positive. And I forgot what trap stands for. I'm going to see if I can't find it really quick. TRAP stands for tartrate resistant acid phosphatase for those who care, but I'm just going to remember TRAP personally. Going down the line to CLL, that would be chronic lymphocytic leukemia. That's an important distinction to make because chronic lymphocytic, because it deals with not the precursors, but the actual B and T cells themselves. The reason why we make that distinction of not just lymphoblastic and lymphocytic, but also acute and chronic is because acute will have a much shorter life expectancy versus chronic. Because if you have lymphoblasts that are affected, you are not making any lymphocytes, you have no immunity. Whereas with the lymphocytes, you can have a little bit of immunity, you'll live longer, therefore it'll be chronic. The chronic lymphocytic leukemia is associated with a few different mutations. One of them would be trisomy 12, another one will be the 11 chromosome deletion of the ATM gene. Another one will have a mutation of the 17q arm chromosome, which has a very poor prognosis, along with the 11q del. And then you'll also have a BCL2 increase mutation. You'll present with quote unquote fleshy lymph nodes, also painless lymphadenopathy is pretty important. You'll also have your fatigue, anorexia, weight loss, super non-specific. And it is in general the most common adult leukemia. For histology, you'll see small mature lymphocytes and smudge and basket cells. So smudge cells because the lymphocytes are kind of broken, they've popped and they're basically smudged on the smears. So they'll look basically like a mess. I have a sad face next to it because why not? For the labs, again, I mentioned the CD5, that's pretty important because again, this is usually a T cell marker, but it will be seen on B cells, which is with the CLL. You'll also have your 19 and 20, again, B cell associated. And then the important other distinction is having a CD23 positive. Next, I want to go to, I will talk briefly about Burkitt's. So it is kind of under the guise of an ALL, but it's also kind of a lymphoma, which is weird. So I will talk about it now before I forget about the leukemia part of it. There's several mutations that it's associated with. The most common one will be the 814, but you also have 822 and 28. So just remember 8's involved and 2 is also involved. And you'll remember 22 and 2 and 8 as well. But again, the one we really care about is 814. It increases, it has a mutation in your CMYC gene, and it is a pretty aggressive and extranodal disease. It's curable in children, and it's the most common childhood non-Hodgkin's lymphoma. Again, we'll talk more about lymphomas after I finish the leukemia, since we have a few more. For presentation, for the African variant, it can present as a mandibular mass, but the sporadic variant, it will present as an abdominal mass. It's also associated with HIV. And on histology, you'll see the starry sky of, I don't remember how to describe that specifically, if there's anything else important with starry sky that you all have. No? Okay, starry sky. Moving on to the rest of the leukemias, we're going to shift to the right of the hematopoiesis to the myeloid cells. So we have our AML, our acute myeloblastic leukemia. Again, blastic because we are dealing with the precursors. Acute again because you have no precursors, you have no immunity, you're going to die more likely. And then also briefly before I continue, I also drew out the pathway of the precursors. So you have your myeloblast, promyelocyte, myelocyte, and then metamyelocyte. There's general changes in the shape of the nucleus, but I think one of the more important distinctions is to make that the chromatin is more fine with the myeloblasts, and then as you progress more and more, it becomes more coarse and clumped. So if they've described that, because having done a few board questions already, they did describe the chromatin, that's a good clue for you to know. where you are at in the disease state, whether you're the myeloblast or myelocyte. Regardless, going back to AML, it is most associated with your 821 translocation, and it will be MPO positive or your myeloperoxidase positive. You will have crystals of aggregates of those, which I should have written a description because I wrote a lot of description of the other ones, but if you look at the blast that I drew, there's granulations and there's also our rods, which are the crystal inclusions, which are the aggregates of MPO. Shout out to Crystal for the spreadsheet. You'll see greater than 20% of myeloblasts in your bone marrow, which means again, it's a leukemia, right? You're gonna have more myeloblasts in your bone marrow than normal. A subtype that's important to know is your M3, which has smaller granules than your AML. I believe it's also known as, let me see if I can find the name in our spreadsheet, acute promyelocytic leukemia. The translocation with that is 1517, and you can treat it with ATRA. And I believe there's a question on knowing which, actually we had a board question where it said which receptor it worked on, and I believe it was on 17, but I do not have that information right now. Look at your board resources for now. It was 17? Thank you, Anthony. Moving on to CML, chronic myelocytic leukemia. I'm making that distinction one more time. Rewind if you've missed that explanation. But your translocation that you're dealing with is, again, your 922. Again, your Philadelphia chromosome. So CML and BALL are your two diseases that you think of immediately when you see the 922. It presents with abdominal fullness, fever, sweats, and anemia, which are, super non-specific. For your histology, you'll have your hypercellular marrow. So normally your bone marrow will have a lot more fat in it. So I kind of drew that at the hematopoiesis by the bone, where you'll have your bone on the outside and then your bone marrow on the inside. What else? So yeah, hypercellular marrow, you see less fat deposits or fat bodies, and it's more filled with cells. For labs, what you'll have is white blood cells greater than 100K per milliliter. You'll decrease your LAP or your leukocyte alkaline phosphate, which is an important lab to know. You'll also have eosinophilia and basophilia, or as both increase. So if you see those on a test, you're more likely to think CML. Your blasts will be less than 10%, which is a distinction to make versus AML, because again, myelocyte, you're dealing less with blasts and more with the sites themselves. You'll have more erythroid precursors and then spleen extramedullary hematopoiesis. For next, you'll have your MDS or your myelodysplastic syndromes, which I believe we put under a different. Yeah, we put those under neoplasm. So I will talk about those later. Let's go back to the lymphomas just to keep the organization there. For lymphomas, we've already talked about Burkitt, where apparently we think of it more as a lymphoma, but we've had lectures where they talk about it as both a leukemia and a lymphoma. So I'll skip the Burkitt for now since I already talked about that. We have an important distinction to make with non-Hodgkin's versus Hodgkin's lymphomas. Non-Hodgkin's lymphomas are kind of more diffuse versus Hodgkin's, where it is more localized. So when you have lymphadenopathy with non-Hodgkin's lymphoma, you might have it more spread out throughout the body. Whereas, for example, if you have lymphadenopathy mostly in the neck, you're more thinking of a Hodgkin's. But starting with the non-Hodgkin's, besides Burkitt, oh, I might have missed actually for Burkitt the lab values, but you see them there. The important one to know is BCL6 and your CIGM and your SIGM, which are your cytoplasmic and surface IgMs. As a side note, apologies for missing that earlier. For follicular non-Hodgkin lymphoma, so it's based on where on the lymph node. I kind of drew a very, very small diagram of like the different zones of a lymph node. Follicular will be more in the dermal area, the translocation it's dealing with is the 1418 BCL 2 to 14. So it goes from 18 translocates to 14. Usually these are in numerical order, not in the order that's translocated. So if you want to make that distinction, the presentation is you'll have infiltration to the marrow, the liver, and the spleen, and you'll also have lymphocytosis greater than 20,000 on your labs. You will be CD20 and CD10 positive, and you'll basically have a butt cell on histology where it's not exactly indented like the mantle cell. So speaking of indentation with the mantle cell, translocation 11 to 14, cyclin D, which is on chromosome 11 to 14. It will affect your G1 to S phase of your cell cycle, where it makes it, proliferate more because you have a lymphoma where you have uncontrolled duplication and replication of cells. Presentation is painless lymphadenopathy, hepatosplenomegaly, and it's a poor prognosis. So it is one of those diseases you think of when you hear painless lymphadenopathy. And I will try to reiterate those once I finish the lymphomas and leukemias. You have your IgM and D levels that you're going to see as abnormal. You're also going to be CD20 and CD5 positive, which is important. And then cyclin D1 will also be increased because again, you're dealing with the cell cycle from the G1 to S part. And then for your histology, your lymphocyte is going to have an indentation on the nucleus. It's not going to be, going in as deep as the butt cell, but it will not look as round as it should. For marginal, which will be on the outside, T11, 18, these will involve mostly your memory B cells, and that's an important distinction I almost forgot to make, whereas your follicular and mental will deal with your small B cells. Usually marginal is because you have chronic inflammation. You'll present as nodal with, the nodal presentation is you'll have enlarged lymph nodes and spleen. Extranodal presentations you'll have affecting your salivary, thyroid, and stomach, and it's also associated with H. pylori. On histology, what you'll generally see is the marginal zone will be much more expanded than it's supposed to be. So imagine I didn't really draw where it's supposed to be, but imagine it only goes a little bit around the mantle. Now imagine it going like 3 times as far. That's what if you see that on histology, you'll think marginal zone. For DLBCL, DLBCL stands for diffuse large B cell lymphoma. This will be it'll be de novo, which is new, or it'll be caused by transformation from your low-grade lymphomas. It is the most common NHL overall, and if you see a description of the cells growing in sheets, then automatically you'll think you're DLBCL. For presentation, it'll be high grade and rapidly enlarging mass. You'll be looking for your IgM and IgG, as well as your BCL6, BCL2, and MYC on your labs. So BCL6, if you see that, you'll think either Burkitt or marginal. And then on histology, what you'll do is you'll look for abnormal mitoses. So here I kind of drew, a bunch of normal lymphocytes with the purple dots, but then you'll see some where it's kind of like, a line or like an angle or a bunch of weird stuff. Those are your abnormal mitoses. If you see that, you're thinking DLBCL again. Going to your T cells. When you're thinking T cells, you will be thinking of your Sézary, mycosis fungoides, and ATLL. So everything else has been a B cell lymphoma so far. So your Sézary and mycosis fungoides, they both share Sézary cells, which are basically your nuclei are going to look like they have folds. I drew it exaggeratedly. It's not going to look as clear, but you should be, careful when you're looking at histology. If you see, instead of a uniform nucleus, you see kind of like the line going through it. Those are your folds. That's your cerebriform nucleus. For Sézary cells, it's usually because you have erythroderma and leukemia of your Sézary T cells. Mycosis fungoides, you have a presentation where you go from a rash to a plaque to tumor cells. For ATLL, which stands for, hold on, let me see if I can find it real quick. Anyone know what ATLL stands for? Okay, adult T cell lymphocytic leukemia. Thank you, Anthony. This one is usually associated with a virus, the human T lymphocyte virus 1, which you will see a lot in Japan and the Caribbean. So if you see those, if someone has visited those places or lives or comes from those places, you'll be thinking ATLL due to the HTLV1 virus. Well, I guess virus 1, you know. Presents with rash, adenopathy, hepatosplenomegaly, and lytic bone lesion. So lytic bone lesion will be pretty big because only a few diseases present with that. You'll have present with your cloverleaf cells or cloverleaf nuclei. So if you see something that looks like a flower or cloverleaf, ATLL. For Waldenstrom, this one will be a mutation in MYD88. It's generally associated with hypersensitivity. You will present with visual and neuro changes as well as cryoglobulinemia, and you will have no bone destruction. You will have your IgM and CD20 that you look for on the labs, and then in the histology, you'll see Dutcher bodies, which you'll see inside of the nuclei. I think that is all for the Hodgkin's. Almost forgot about Hodgkin's. Hodgkin's is the other distinction from the type of lymphomas. I would describe it as one big difference is it's a localized lymphadenopathy versus diffuse. It's often associated with Epstein-Barr virus. So if you're looking for, a test where you have your heterophiles, if they say that on a exam where you're thinking about lymphomas, you'll automatically think Hodgkin. It'll increase your risk of secondary cancers, so breast, lung, AML, and MDS. It is also a bimodal distribution of age, so you'll generally see it in either people in their 20s or around 65. That's so if you see, a question that talks about bimodal for some reason, or they talk about someone in their 20s or 65, this will be one of the diseases you think about. It'll present with enlarging cervical and mediastinal lymph nodes with contiguous spread, contiguous again meaning close by. It'll have, again, painless LAD is pretty big for this. And you also have your B symptoms again, your fevers, night sweats, and weight loss. And then you'll also have, even though you have painless lymphadenopathy, when you drink alcohol, you either have bone pain or lymphadenopathy pain. So that's pretty big. If you come in with someone saying, hey, ow, I have a lot of bone pain after I drink some booze or something on the exam test, you'll think Hodgkin's again. There's different types of Hodgkin's. So you have your nodular sclerosis, which is the most common type. You'll have your lymphocytic rich, which is your best prognosis. Then you have mixed cellularity, which will have involved higher levels of IL-5. Then lymphocyte depleted, which is associated with HIV, your liver, your bone marrow, spleen infiltrates. For labs, you'll look for CD15 plus, 30 plus, and the big thing here is 45 minus. And then for histology, Reed Sternberg, you got your owl eyes. That's one of the big things as well for histology. You see that? Hodgkin's, nothing else. Get it out of your head. Going back to the right, talking about the myeloproliferative and myelodysplastic syndromes. So for myelodysplastic syndromes, that's when you have defective maturation. And so because of that defective maturation, you'll have cytopenia, you're lacking all of these cells that we're talking about for hematopoiesis. Primary is idiopathic, probably genetic, but secondary, it is related to genotoxic drugs and chemotherapy. So if someone's with chemotherapy, you'll think a lot of MDS. It will have mutations in T53, TP53. And then on labs, you'll have TMDS that you'll see, and then increased blasts. Because again, cytopenia, you have no cytes, you have blasts. For myeloproliferative disorders, or neoplasms, there's two types we generally talk about, but CML also falls under the category of myelodysplastic neoplasms. You'll have your polycythemia vera. Usually it's an indolent disease, and it deals with your JAK2 receptor mutations. You'll see an increase in hematocrit, and this will, again, I missed this, it will involve red blood cells in general. So you'll see an increase in your hematocrit and your hemoglobin. You'll also see a normal PO2, increase in platelets, and those platelets will generally be large, and a decrease in erythropoietin, which makes sense because if you have too many red blood cells, you want to downregulate that. So on histology, you'll basically see a bunch of crowding of red blood cells, which I tried to illustrate there. Your second type of MPN will be your essential thrombocytopenia. 50% of those are also a JAK2 mutation. You'll see just an increase in abnormal platelets, and that's pretty much it. Another thing to note with CML is that it can progress to either AML or ALL, and which is interesting to make that distinction because I believe CLL is only can go to ALL as well. So if you see that sudden change, there'll be some questions where they ask, you have a patient where you know they have CML. What's the most important change that increases their mortality? Something you might think about is either AML or ALL, where you go to acute disorders, which again, your prognosis is super short. Any other questions on the leukemias, lymphomas before I move on to immunodeficiencies? Everything's making sense?
I was just confirming, so B ball has B likes B symptoms?
Yes, ball has B symptoms.
I find that, so.
I had it somewhere. I think I added it because of a board question. Yeah, there's some things on here that I added because we did random board questions that aren't on what we were taught. So do keep in mind that this is mostly based off of lectures, but I don't know if anyone's been listening to this part of the recording. Moving on to immunodeficiencies. We have two different groups of immunodeficiencies. We have humoral immunodeficiency and then combined immunodeficiencies and then complement deficiencies. I will start by talking about the humoral immunodeficiencies. Something to note for those is that they will mostly present with pulmonary and sinus and pulmonary infections. Whereas the combined immunodeficiencies will have that, but they'll also have soft tissue infections. So as we're talking through this, when you hear soft tissue infections, you'll mostly think the combined immunodeficiencies. But moving on to humoral, I'm going to start talking about the Bruton X-linked immunodeficiency. This one, the mutation is in the chromosome 22, or the X chromosome, the Q22 part of it, where it's a mutation in the BTK protein. The infants will be normal for the first 6 months of life because they still have their mother's immunoglobulins still floating around and circulating. But once those are gone, you'll start having symptoms. And so what they'll present with are absent tonsils and lymph nodes. And why are they absent is because you don't have any proliferation and differentiation of your B cells. And so you're not going to really have anything floating around in your lymph nodes. They will be underdeveloped. You will have recurrent URIs as another presentation as well. And on labs, again, you'll have absent B cells, and then you also have decreased IgA, G, and M. Because again, if you don't have B cells, you're not going to have plasma cells and you won't make immunoglobulins. Next, talking about isolated IgA deficiency. What you'll present with as you're deficient in IgA, which covers all your mucous membranes, it is recurrent sinopulmonary infections, which makes sense. Those are covered in mucous membranes. You also have chronic diarrhea and malabsorption, which your GI tract is also lined with mucous membranes, and therefore having a deficiency in IgA will affect those. When you're looking for labs, you're going to have normal levels of IgG and IgM, obviously, because it's isolated IgA, decreased IgA as well. Even though you have less IgA, you still will have your normal cell-mediated immunity. So that's an important distinction to make. Next is your transient hypogammaglobulinemia. Oh my God, I said that first try. This is a disease where it's temporary. Infants are usually just slow to produce IgG, but eventually they get there. So it will usually resolve by about 3 to 6 years old. As you present, you can be asymptomatic, but if you're not, you'll have minor infections usually. You can also present with eczema and food allergies. In general, you'll have, again, less IgG, which is one of the first immunoglobulins alongside IgM that your cells will make. And we talk about, being slow to produce IgG. You may have normal or low IgA and normal IgM as well. And you'll have normal levels and normal looking B and T lymphocytes. They're going to be fine. Again, it's just going to resolve on its own. Next up, we have common variable immunodeficiency. It's a B cell immune disorder where your maturation is arrested. So you'll have recurrent sinopulmonary and GI infections. You'll also have a big distinction is your failure to thrive. So when you see failure to thrive, you're thinking an immunodeficiency, common variable. You also have pulmonary sequelae, which makes sense if you don't have any maturation of B cells. You have complications with pulmonary infections. There's also a risk of eventually developing autoimmunity, which I find interesting. Allergic disorders and also malignancies, and again on labs, because if you have no B cells, you have low of basically all your immunoglobulins. I believe that is all the humoral deficiencies. Moving on to our combined immunodeficiencies. So starting up, we have SCID or severe combined immunodeficiency. There are 3 different diseases that fall under this umbrella of SCID that is under combined immunodeficiency. You gotta love that. First, you have your adenosine deaminase deficiency. Usually you'll present with symptoms in your first 3 months of life, and you'll have recurrent and severe infections. And again, pretty important distinction of failure to thrive. You'll have no lymph nodes, because again, if you don't have any B cells or any humoral cell mediated immunity, it's going to be underdeveloped, and you also have a hypoplastic thymus, which is consistent with your lymphopenia, and with lymphopenia, you also have low levels of all your immunoglobulins. Your second SCID will be your gamma chain IL-2 receptor defect, which is also known as CD132, and it'll have your RAG1 and 2 defects as well. There's not much else that they really said about that. The last SCID will be your Wiskott-Aldrich, which is your X-linked recessive disease dealing with your WASP protein, or also known as your Wiskott-Aldrich syndrome protein. They're so creative. You have a loss of function of your B and T cells, and so you can imagine that's going to be detrimental in decreasing all your immunoglobulins, which we'll see in the labs in a moment. You'll present with infant eczema and infant infections, as well as petechiae and unusual bleeding. Again, you'll have your decrease in maybe normal IgM and G, but decreased IgA and E and decreased vaccine response. So that's why I kind of do the little syringe there. To remind us of that. The next disease that also has decreased vaccine response, very fittingly, next to it is ataxia telangiectasia. It is an autosomal recessive disease where you have a DNA repair deficit and therefore decreased B and T cells because they can't repair their DNA. You'll generally have symptoms presenting in your first 6 years of life, where you have scleral telangiectasia, progressive cerebral ataxia, which will eventually lead you to being wheelchair bound at 12, and then also eye movement, cognition deficits, and chronic sinus pulmonary infections. For labs, you'll have lymphopenia, decreased IgG, M and A, and alpha fetoprotein, and decreased vaccine resistance again, or response. So, indeed, particularly for these 2 diseases, you do not want to use live attenuated vaccines because that has the potential to evolve into something very harmful for our little children. Welcome, Devin. If you have any questions, always feel free to interrupt. Next disease we'll talk about is your X-linked hyper IgM, which is a class switch defect because you generally start by making your IgM and then class switch to your IgA, D, G, and E. Hope you remember that FOM. It also will have a deficit in CD40L, and so if you have a deficit in CD40L, looking at the cell-mediated pathway in blue, you'll basically not be able to have cell-mediated immunity at all. You'll have an increase in your IgM, again, because of the class switching deficit, and a decrease in IgG and A, and then an increase in leukocytes because your body's probably trying to compensate for lack of other immunoglobulins, just my thinking. Next, you'll have your hyper IgE. It is an autosomal dominant disease where you also have T and B deficits as well as neutrophil deficits and then interleukin and cytokine deficiencies. You'll present with, I don't know why what are there. You'll present with facial and skeletal abnormalities. So something talked about, for example, scoliosis. And for the facial abnormalities, there's like a characteristic set of facial abnormalities that they didn't describe to us. So who knows? You'll also have seminal pulmonary infections and skin and soft tissue infections. Again, soft tissue infections are more with combined immunodeficiencies than humoral. You'll also have 2 different mnemonics. You have your 3 E's and faded. So 3 E's, your IgEs increased, you'll have eosinophilia and eczema. For faded, we've kind of talked about some of these already. You have your quartz facies, some of your facial characteristics. You'll have abscesses, you retain your primary teeth. Which means I think you don't lose your primary teeth, they didn't explain that. But then you also have, again, increased IgE levels, and then for derm, eczema. Another deficiency that I will talk about that didn't really fit in the humoral and combined immunodeficiency is your bare lymphocytes, where you basically have your MHC deficiencies. So MHCs are expressed on the outside of cells. If you have a deficiency there, then you can imagine that you have a loss in your humoral and cell-mediated immunity. There's two different types of bare lymphocytes. The immunodeficiencies, type 1 is your cat defect, where you only lack your MHC1. And your type 2 is generally more severe, where you have your A-gamma globulinemia. Because again, if you don't have any humoral cell-mediated immunity, you're not going to really make any immunoglobulins. The last immunodeficiency I will be talking about will be the complement deficiencies, where it's in your complement pathways. There's different types where you have them early on, later, or like at the very end. So early on, you have your C1s and C2. C1q deficiency is generally associated with lupus. C1 will be associated with hereditary angioedema, and lack of C2 will be involved with pneumococcal infections. If you have a C5 through 9, which will be your MAC deficiency, then you'll see a lot more Neisseria infections. And then you'll generally assess for these with the CH50 assay. Any questions on the immunodeficiencies?
C3.
C3?
Include that if you're missing that, you get recurrent pyogenic infections.
I did not. So Anthony's saying if you lack C3, then you will have a lot of recurrent pyogenic infections. I will add that to the board, or I'll add it now before I forget. Or do you want to add it?
Fine.
Also, Devin, feel free to chime in with any knowledge, because again, I'm missing a lot.
I don't know anything, so this is very helpful.
Pyogenic infection. All right. Moving on to our anemias. Lovely. We have a lot of those. If we are ready to move on. Anemia obviously involves red blood cells. There's different types. The main subcategories I'll have in here are your underproduction, your normocytic, macrocytic, and microcytic. Macrocytic, we've talked about so much. I will start with that just to get that out of the way. So macrocytic, you'll have your B12 and folate deficiencies. For B12 deficiencies, the lab that is very indicative of that is your MMA increase or methylmalonic acid. You can have a type of B12 deficiency called pernicious anemia, where you have antibodies against your intrinsic factor, which is used to absorb your B12. You can also have antibodies against the intrinsic factor and the B12 complex itself, so that it's not able to bind to tubulin and absorb. Or you have destruction of your parietal cells in your stomach, which will release your intrinsic factor. For both folate and B12 deficiencies, you will have for your labs a high homocysteine as well. And then obviously just low folate and B12, depending on which, but low B12 will also lead to low folate. If you also have neuro symptoms, you'll most likely think B12 deficiency. For a macrocytic anemia, one of the characteristics histologically that you'll find is besides having your macrocytic cells, your large cells, you also have hypersegmented neutrophils. So I should have drawn that on here. But your neutrophils in general should only have about 3 to 5 lobes. And if it's hypersegmented, then it will have 6 plus. So that's one way to just immediately distinguish what type of anemia am I having. We're just going to draw that really quick. So that's the very brief on the macrocytic anemias. I only talked about it just because we've talked about it so much. 5, 6 lobes, I guess. In a second. Next, I will talk about your microcytic anemias. There's 4 of them that we're generally going to talk about. One of them is going to be your iron deficiency. It makes sense. No iron, no hemoglobin, no red blood cell growth. Your cells are going to be microcytic and hypochromic. I probably should have written descriptors for the rest. You can have iron deficiency for several reasons. Increase in demand, such as, infant growth, or if you become pregnant. You can also have blood loss, malabsorption, which are also usually associated with celiac disease or a gastrectomy, for example. For your labs, what you'll have is a decrease in serum iron and decrease in ferritin and transferrin saturation. You'll have an increase in your TIBC, your free erythrocyte protoporphyrin, and then EPO, as well as increase in protoporphyrin. An important distinction to make as we talk about these labs is that TIBC, or your transferrin binding capacity, yes, transferrin binding capacity. That one is usually associated with your ferritin, and they're always opposite. So if your ferritin goes up, your TIBC goes down, and if your ferritin goes down, your TIBC goes up. This is because ferritin is the storage form of iron. So if you have more iron storage, you want to make less transferrin because you're not going to be wanting to transfer to places where you can use it, right? You want to store it more. So that's why you'll have your reciprocal increase or decrease. Another important distinction to make is your transferrin saturation is also going to be dependent on your serum iron levels. So if your iron levels are down, then your transferrin saturation is also going to go down just because there's simply less to bind to the transferrin. So keep that in mind as trends as we talk about labs. On histology, what you'll see are, again, your microcytic and hypochromic blood cells. So on the right, I kind of drew two larger blood cells with more quote unquote hemoglobin, so it looks more filled in, whereas the left three cells are smaller and they're more see-through, so they don't have as much hemoglobin. Next, I will talk about your ACD, or your anemia of chronic disease. This is your most common type of anemia. Again, think hospitalizations, right? Where if you have a lot of people being hospitalized, usually they're in there for some sort of disease that's causing inflammation. So speaking of inflammation, when you have inflammation, you will release your IL-6, which will increase your hepcidin, which will decrease your macrophage ferropoietin, which decreases your EPO. So why do you want to do this? It's because when you have inflammation, generally, a lot of times it's going to be because of an infection. And so if you have an infection, going to be bacteria in there. They use iron to reproduce. So decreasing iron storage in your blood will decrease that access to bacteria. It'll slow down their proliferation. And so again, the iron will be kept in your macrophages, and again, less for infections. So what will you see on labs? You'll see an increase in ferritin, an increase in free erythrocyte protoporphyrin. And then you'll also see a decrease in TIBC, serum, Fe, and your decrease in saturation as well. Next, we'll talk about sideroblastic anemia. There's two different types. Your primary, which will be a defect in your ALAS gene or protein, and then your secondary, which is associated with alcoholism, lead poisoning, or decreased B6, as well as tuberculosis treatments. This is an issue in protoporphyrin synthesis, and so if you have less protoporphyrin, you're going to have less red blood cell creation. You will lower for labs, lower hemoglobin in general, as well as lower TIBC. You have increased ferritin and increased iron use, which again, if you have less protoporphyrin and you're not making hemoglobin, you're not going to use that iron. The storage is going to go up. You'll have also an increase in erythroid precursors with, they say 5+ mitochondrial iron deposits. And so on that red blood cell, I kind of drew in like a bluish tint around it, a bunch of little blue dots. Those will be your iron deposits on histology. So that if you see that, sideroblastic rings, sideroblastic microcytic anemia. Last microcytic anemia, and probably one of the most important ones to talk about, is your thalassemia. You have two different types based on what type of hemoglobin is lacking. You have your alpha thalassemias, which have a deficit in your alpha hemoglobins. This is on your chromosome 16, and it's usually a deletion mutation. You will see different diseases such as HbA and Bart's on cells. So HbA is when if you don't have any alpha hemoglobin, all your beta hemoglobins are just going to aggregate and create your HbA. And in types of diseases, you'll have your silent mutation where you're only missing one because you have four different alpha hemoglobin genes on your cells. So if you're missing one of the four, it's a silent mutation. You still have plenty of alpha to bind to betas. If you have alpha trait, you're missing two of them, and there's two different ways you can have that mutation. So since it's on two different chromosomes, you can either miss both on one chromosome or one on each chromosome, and so those will be cis and trans. And those are associated with, which one is the only Asians? Is that cis or trans?
Trans.
So Asians only is cis, and then
Cis, yeah.
Africans and Asians are trans. In terms of those mutations, and then if you have no alphas at all, that's fatal hydrops fatalis, dead baby. If you have your beta thalassemias, this one is where you only have two of these, so one single pair, and these are usually point and splice mutations on your chromosome 11. You can have two different types. You can have B0, that should be a 0, not minus, but major, where you basically have no betas being made, and so that's obviously more severe. Or you also have B minor, where you just have a deficit in your Bs. In presentation, you'll have chipmunk facies as well as a crew cut skull. Crew cut skull because if you're lacking one of the hemoglobins, you're going to try and overproduce. Your spleen's not going to make enough red blood cells, so you're going to go to other weird bones, such as your skull, where you don't normally have as much hemoglobin and erythrocyte production. For histology, what you will see is target cells, and that's only on major. So you might not see anything on minor beta thalassemia. Moving on from the microcytics to probably our biggest group, our normocytics.
What happened to lead?
Lead poisoning?
Yeah.
Oh, son of a marshmallow. Lead poisoning, just remember that. I will add that as an addendum probably on the board. Moving on. Thank you, Anthony. Normocytic anemias. You can split those into two different groups. Your non-hemolytics and your hemolytic anemias. Non-hemolytic anemias are associated with chronic disease, aplastic anemia, leukemia, which is cancer, which leads to fibrosis of your bone marrows and therefore less in production of your red blood cells, and renal disease, where if you have it severe enough, you decrease your EPO production, no red blood cells. For hemolytics, there's two different groups. Well, actually four different ways to categorize it. You can categorize it as either intrinsic and extrinsic, or extravascular and intravascular. Intrinsic is usually due to a reason of gene or protein defects. Extrinsic is usually something outside, so like mechanical damage or chemical damage. Extravascular usually happens outside your blood vessels. So for example, in your spleen or liver where stuff is recycled a lot. And intravascular is within your blood vessels. So again, if you have like mechanical damage inside your vessels or chemicals inside your blood vessels, it will lead to your intravascular. Something to note is that intrinsic can be both extravascular and intravascular, whereas your extrinsic hemolytic anemia is only going to be intravascular, as I tried to color code and make that nice and pretty. So we're going to start with our intrinsic and extravasculars. So in general, what you'll see on presentation for extravasculars overall is a lot of hyperbilirubinemia and jaundice and splenomegaly. Again, you're involving your liver and your spleen, so those are symptoms you'll see a lot. In hereditary spherocytosis, it is an autosomal dominant disease with a defect of ankyrin and spectrin, which are your anchoring proteins for your membranes. If you do not have those, you do not have your little disc shape of your red blood cells turned into spheres. What that presents with is variable anemia and reticulocytosis and hyperplasia of your bone marrow. So, or hypercellularity, I mean, because if you have, a bunch of spherocytes that are, again, being recycled because they're defective, you're going to try and make more cells to compensate. For spherocytes on histology, they will look small, a little smaller than your blood cells, but they'll also look filled in all the way instead of, a little hollow disc on the inside. You might also see your Howell Jolly bodies, which are usually just like small like deposits, usually one or two at most, on some of your spherocytes specifically. Again, you'll have an increase for labs in RDW, which is your basically your distribution of widths of red blood cells. So normally that's usually tighter, but if you have spherocytes, some will be a lot bigger or smaller. Your RDW, your distribution of widths, unlike a bell curve, for example, of the widths is going to increase. And then you also have an increase in MCHC, or the volume that blood cells hold in blood. Hopefully I'm explaining this correctly. I don't know my labs that well, unfortunately. Would that make sense with if you have spherocytes as well? Two tests that you can use to test for this are your osmotic fragility and your flow cytometry. And again, just one thing I want to note is important is when you have the spherocytes, your spleen's going to kind of try and get rid of them because they're defective, and then you'll have your splenomegaly. Any other comments on the hereditary spherocytosis? Okay, moving on next to probably the most famous one of all, sickle cell. This is again a chromosome 11 because it's dealing with your beta hemoglobin. It is a mutation from glutamate to valine, and it's also autosomal recessive. For presentation, you'll have your crew cut skull again because you're trying to make up for those defective cells by increasing proliferation of red blood cells. You're going to go to weird places such as your skull where normally the blood's not made. You'll also present with hand and foot syndrome, thrombotic disorders, which makes sense because the sickle cells, they like to clump together, and as well as an aplastic crisis, which means you might not be able to make enough blood cells. Or you can have either disease or trait. With disease, you only have a mutation in both chromosomes, and in trait, it can be asymptomatic. You have disease only in one. Histology, you'll have your sickle cells, and then for tests, you can test your hemoglobin electrophoresis so you can see what is abnormal. So disease will have more hemoglobin sickles, so HBS, it'll be about 90%. No HBAs, which is important, but you'll have some HBA2s. Whereas your trait, you'll have a lot less sickles, so about 43%, and then you also have a lot more HBA as well. The next extravascular we'll talk about is having HBC, which is a mutation again in your hemoglobin beta, which is on chromosome 11. It's autosomal recessive, and it's glutamate to lysine mutation. You'll have on histology HBC crystals, which as I show, two normal blood cells kind of, but then one kind of looks like a rod or like a crystal abnormal. And then for tests, you can use HB electrophoresis again to categorize your hemoglobins. Those are all your intravasculars. Next, I'll be talking about your intravasculars, which includes some intrinsic diseases. So starting with paroxysmal nocturnal hemoglobin. This is a disease in a mutation of PGIA, which makes your PGI, or PIG, what the heck, which is a membrane anchor. And if you have a deficit in that, then you also have a deficit in GPI, which is another anchor glycolipid. And then therefore you don't have DAF. I don't know what it stands for, but it doesn't bind to GPI. And if you don't have that in it, which I think it should inhibit complement, you'll have cell mediated damage without it. And so that's why you destroy your blood cells. Something to note as well is that it only happens at night, because when you're sleeping, you're breathing a lot slower. You're keeping more CO2. More CO2 will lower your pH. And so that drop in pH will cause the proteins to become defective, and therefore you'll have your hemolysis while you're sleeping. This will also be important to note for one of the tests I'll talk about in a moment. But something you'll present with is your nocturnal hemolysis, obviously, pH down through the breathing, and you also have thromboses as a presentation. For labs, you'll have hemoglobinemia and hemoglobinuria, which makes sense. You're popping your cells, it's going to be in your blood and your pee, as well as hemosideruria. That for tests, you can use a sucrose test to just screen for it, but acidified serum test is going to be confirmatory because again, it'll mimic your lower pH in your blood when you're sleeping. Something that's important to note is that DAF is also known as CD55, and you can test for that to confirm. If it's not on your red blood cells, confirm this. Next we'll talk about your D6PD or
Sorry.
Yeah.
Isn't that one also associated with malaria?
CD55.
No, paroxysmal nocturnal. Well,
Is it with malaria?
Um,
I haven't looked at malaria yet, so it could be. So the note potentially associated with malaria. Thank you
maybe
guys.
that's thrombocyte.
I think both. Well, thrombocytopenia. Oh, did I not do that? Oh, I did do that later. Moving on to G6PD. It's an X-linked recessive deficiency of your G6P. You will see this mostly in Mediterranean and African American or in African and Asian populations. I don't remember why I wrote AA, but it's usually for protection against P. falciparum. This deficiency leads to an increased oxidative stress on your red blood cells. And so what you'll see in your histology are going to be your Heinz bodies, which are kind of like Venus deposits in your red blood cells, as well as quote unquote white cells. Next deficiency is going to be pyruvate kinase deficiency. Generally it makes, turns glucose into pyruvate, which you can use for a lot of different things, such as your Krebs cycle. So what you're going to basically have is a failure to maintain your shape, I believe, and so that's where you're going to get your Burr cells on your histology, where it looks like a blood cell with kind of like spikes going all around it. Next, I want to be talking finally about your extrinsic hemolytic intravascular anemias. So first one we're going to talk about is your immune hemolytic, which is going to be IgG and IgM mediated destruction of your red blood cells. So you can have two different types of immune hemolytic anemias. One is going to be warm, where it's specifically IgDs to red blood cells. You'll have your splenic macrophages involved with this. It can be idiopathic or secondarily, which makes this extrinsic. It can be associated with lupus, chronic lymphocytic leukemia, as well as certain drugs such as beta-lactams and alpha-methyl-dopa. Something you might see on histology as well is spherocytes, in particular for the warm. For your cold immune hemolytic anemia, this will be your IgM, and it will agglutinate. And if you remember from FOM5, this is associated a lot with mycoplasma. So if you have a mycoplasma where you're cold, you have a positive agglutinin test, you might also have an immune hemolytic anemia. You have two different tests to test for this. You have your direct clumps, which will have antibodies that will clump your RBCs together. So you basically throw in a bunch of antibodies into the blood. If you see a clump of cells, then that's a positive. You also have your indirect clumps, where instead of trying to clump your red blood cells, you'll throw in a bunch of test red blood cells, as well as an anti-antibody for IgD. And then if you have the antibodies that will clump your blood cells, then you'll clump the antibodies instead. And so, which confirms again the presence indirectly. You can also have on your labs unconjugated bilirubin, a decrease in haptoglobin and reticulocytes, as well as seeing hemosiderin and polychromatophilia on your labs. For your histology, again, we're talking about a clumping disease. You'll see a bunch of clumping of red blood cells. For the microangiopathic hemolytic anemia, these are usually due to a mechanical destruction, such as prosthetic heart valves. You can also have it be caused by microvascular lesions. So you have plaque buildup in your smaller vessels. The red blood cells are going to bump against those and they will become damaged. And then you'll get what is called your schistocytes, So you'll have like your hat helmet, there's some other schistocytes, but they basically look like red blood cells that took a beating. This is also associated again with DIC, TTP, HUS, and SLE, lupus. Diseases where you have a lot more clotting, therefore a lot more platelets, more potential for those red blood cells to become beat up. The last intravascular extrinsic I'll talk about is just malaria. I'm not going to go too much into it because I haven't really looked at malaria that much yet. But if we're talking in terms of histology, you'll see Schaffner's dots inside those red blood cells. Any other questions on the anemias before I move on to our last portion of the lecture?
Sugars are in B5X and Uvalic.
By vaccine volume. Maybe I should do a malaria board, an HIV board. Well, I'll do it. But, all right, hemostasis. There are two different types. Let's finish this. You have your primary hemostasis and your secondary hemostasis. Your primaries are mostly going to deal with your platelets, and your secondary is mostly going to deal with your clotting cascade. So they're starting with our primary hemostasis. There are two different types. One is going to be your quantitative, and then your other type is going to be your quantitative. So quantitative deals with your quantity, and then quality, obviously, for qualitative. So first off, we're starting with ITP, or immune thrombocytopenia. No, purpura. No, immune thrombocytic purpura. Thank you. You'll see this in both kids and adults. The primary reason you'll have it will be antibody-mediated platelet destruction. So no platelets, you're going to have a lot of bleeding, therefore leads to that purpura. Secondary will be due to lupus or HIV. And so, in particular for that, we'll have, oh wait, no, sorry. Going back to the primary, you'll have IgGs that will bind to it generally and destroy cells based off of the GP2B and 3A protein, which tackles the fibrosis. Or there's also acute ITP and chronic. So acute can happen in children after a viral infection, whereas chronic occurs a lot in reproductive age women. That's all I have on that with that description. I don't know what else there is for that, unfortunately. For presentation, you can, again, you have a lot of bleeding, so you have a lot of skin bleed. So petechiae, purpura, and ecchymoses. You may also have melena, hematuria, excessive Metzev flow, and spleen enlargement. On labs, you'll have decreased platelets, enlarged abnormal platelets, as well as increased megacardiocytes. And then your P prothrombin and your partial thrombin time are going to be normal, because again, we're dealing with primary, which is platelets, not the clotting cascade. Moving on to your thrombotic microangiopathies, your TTP, or your, what does TTP stand for? Okay, thrombotic thrombocytopenic purpura, thank you. This will be a defect in your ADAM-TS13 protein, which is a factor that will degrade your von Willebrand, so kind of help control your bleeding. But if you have a defect in that, you will not degrade your VWF, and therefore you'll activate and aggregate a lot more often. And so it could be, if it's secondary, it's usually because you have an autoantibody for it. Otherwise, primary would be that mutation, and you will lose that metalloprotease function. And so this is going to be important when we talk about differentiating this between a TTP and hemolytic uremic syndrome. But going back to TTP, your presentation is going to be a pentad. You'll have fever, thrombocytopenia, which makes sense, microangiopathic hemolytic anemia, neurological deficits, and renal failure. Going to hemolytic uremic syndrome, or HUS. This will be endothelial damage by drugs or infection, and you will usually be platelet rich, have platelet rich thrombi. The presentation is going to be hemolytic anemia without any neurological symptoms. And a classic cause for this, and they'll talk about, is potentially E. coli and from undercooked beef in a kiddo. So another way to, as we talk about labs, a way to distinguish TTP and HUS is your von Willebrand metalloprotease activity. So your activity obviously is going to be decreased in TTP, but the same in normal in HUS. Both will present with thrombocytopenia, increased bleed time, and megacardios, as well as normal PT and PGT, again, not dealing with clotting cascade. So know that you either have neurodeficits and metalloprotease loss for TTP, or no neurodeficits and normal metalloprotease and HUS for distinguishing the thrombotic microangiopathies. Last but not least, we have our qualitatives, which will be starting with our Bernard Solier. It is an autosomal recessive disease with a G1P deficit. So if you have a D1B deficit, you will not be binding to von Willebrand factor for the aggregation of your platelets. You can have variable but often severe bleeds. And for testing, you just do platelet aggregation studies. Treatment would be platelet transfusions and antifibrinogen. Fibrinolytics. For gland span thromboasthenia, it is also a autosomal recessive disease with a GP1B and 3 defect. Again, no binding to fibrinogen, you're not involved in clotting with the clotting cascade, severe bleeds, but importantly, to distinguish this on histology, you'll have no platelet clumping. The last one, we'll also have a TXA2 defect, which is used to convert arachidonic, you have that defect because you're usually inhibiting COX, which converts arachidonic acid to TXA2, which will increase your D1B and 2B and 3A for the rest of the platelet stuff. This is often due to mutations, NSAIDs, aspirins, and uremia. The last one I want to talk about, because it kind of overlaps a little bit with secondary hemostasis, is our von Willebrand factor deficiencies. So if we're talking about type 2 specifically, because there's 3 types, 1, 2, and 3, type 2 is qualitative, and it is autosomal dominant. It's associated with mild mucosal bleeds and skin bleeds. Your platelet count is going to be normal. Your prothrombin time is going to be normal, but you may have increased partial thrombin time. Your PFA 100, which kind of assesses for how much are you willing to clot eliminate, is going to be prolonged, and then you can also use your VOF assay and a Risto-Seam test to assess for that. Going on to our secondary hemostasis, where we deal with our clotting cascade. Again, continuing with our von Willebrand factors, also autosomal dominant diseases for your type 1 and 3. Your type 1 is going to be more mild, and you can treat that with desmopressin, which has the weird effect of releasing more von Willebrand factor. I also do it in blue because it's also more of a quantitative. So again, releasing more von Willebrand factor because you don't have enough. That's going to be your type 1. Your type 3 is also quantitative, excuse me, and it's more severe than 1. You treat that with von Willebrand concentrate, but you can also use desmopressin in that treatment. For labs, it'll be very much mirror the other type 2. So you'll have your increased prothrombin time, increased bleeding time, but normal PT. You'll also have a decrease in your factor 8 half-life, and again, your abnormal Risto-Seam. Moving on, also, I believe, what was it, von Willebrand factor also stabilizes factor 8, or is that something else that stabilizes it? Yes, von Willebrand factor also stabilizes factor 8, so that's why we bring in that factor 8 half-life. Moving on to hemophilia B and A. So hemophilia B, Christmas disease, X-linked recessive. It is a deficit in your factor 9 in your intrinsic pathway. Also, this is a side note, a fun way I like to remember the intrinsic is PTT and extrinsic is PT is you PET Brad Pitt. So PET, PT only, extrinsic, and then PIT, PITT, Brad Pitt. Anyways, moving on from that aside, for hemophilia A, that's also a defect in intrinsic pathways, factor 8. It's the most common type of hemophilia. It's also X-linked recessive, and it will lead to deep tissue, joint, and post-op bleeds. For both, they share similar labs. They have an increase in PTT, which is, again, your intrinsic pathway, PIT. And then they'll have about the same PT, because again, it doesn't deal with your extrinsic pathway, and then your bleed time's about the same. Moving on to acquired secondary hemostasis. We have our vitamin K deficits, which is involved with our factor 2, 10, 7, and 9. So 2, 7, 9, 10. It's often associated with GI and liver issues. If you have a mild deficit, then you'll have an increased prothrombin time, but a normal APTT. But if it's severe, then both will be increased. Treating with vitamin K. Next is your DIC, your disseminated intravascular coagulation. You should watch that YouTube link for a funny, like, weird intro on it. But you'll have excessive coagulation in your microvasculature that uses up all your factors. And so therefore, if you use up all your factors, you're going to bleed a lot. It's often associated with obstetric complications, carcinomatosis, sepsis, APL, or your M3 disease of your leukemias. It all comes back in a circle, and also rattlesnake bites. For presentations, you'll have bleed, jaundice, acute kidney failure, I wrote as AKI, coma, and pulmonary bleeds as well, which the bleeds make sense if you're using up all your clotting factors. So since you use up all your clotting factors, you're going to have a increase in both PT and PTT in both pathways. You'll also have increases in FDP and your D dimer. Your D dimer is important for distinguishing having DIC. You'll also have thrombocytopenia, again, you're using up all your platelets, and you'll have a decrease in platelets, platelet factors, and fibrinogens, schistocytes. Moving on to, we're going to skip embolisms because they didn't really talk too much about embolisms. I just kind of wrote that there just to have it. D dimers are also increased in embolisms. For fibrinolytic disorders, this is usually due to overactive plasmin, which will break up your clots. This is can be either due you just have that mutation. You can also have radical prostatectomy, which will release urokinase, which will increase your plasmin activity. You can also have cirrhosis of the liver, which will decrease your A2 antiplasmin, which will stop the inhibition of plasmin. You'll degrade your fiber. This disease can resemble DIC, so be careful when deciding between DIC. You should use your labs. Again, negative D dimer, no D dimer, no GIC. Then if it's present similarly, then you will think of your fibrinolytic disorders of your plasmin. You'll have increased lead time and again, increased PT and PTT because your plasmin kind of goes against the clotting cascade. So if it has to work against that, your thrombin and prothrombin fiber, so it's going to be increased. Next will be your last set of diseases are generally hypercoagulability diseases. So your first one I'll talk about, I didn't underline it for some reason, has its own thing, but is a protein C and S deficiency. What this does is it will inhibit the formation of active 5 and active 8 factors. And so if you have less inhibition of those, then you'll have more thrombosis, and therefore you'll have more skin clots and skin symptoms and presentations. Next is factor 5 lead-in. So basically you have a mutation in your factor 5 where it lacks a cleavage site and for your protein C. And therefore, if you can inhibit it, you'll have more clots. And it is the most common cause of recurrent UDTs. Next, you have your antiphospholipid antibody syndrome. You have antibodies against cardiolipin, anti-beta-2 glycoproteins. Generally, these will interfere with your phospholipids, and that will lead to more coagulation. I'm not sure the exact mechanism. You will present with recurrent thromboses. Repeat miscarriages is big for this. So if you have repeat miscarriages, you'll think of antiphospholipid antibody syndrome, as well as thrombocytopenia. Last but not least, HIT. It is associated with taking heparins. It is going to be a complex of your heparin and your factor 4s. They will aggregate and usually consume your factors. And when you consume your factors, you're not going to be able to clot. You'll have a lot of bleeding. So you'll be in a constant thrombotic state. You'll present with venous thrombosis, more common than arterial. You'll have skin inflammation at the site of the injections for heparin, and then you also have skin necrosis because you're clotting a lot and around the small vasculature. And you may also present with bleeds due to using up all those factors. FOM6, any other questions?
It's not factor 4 like the clotting cascade, it's platelet factor 4, so it's PF4
PF4, platelet factor
for
4.
heparin, for HIT.
Okay,
It's
platelet
not-
factor 4.
Yeah.
Thank you. And LOs know all of this. I have no conflicts of interest. And the recording, I guess. I like it through the 3.
That was good. Thank you so much.
Is it done?
Is it done?